Well, welcome to tonight's webinar. My name is Pam Getz. I work at Sibley Hospital in the cancer program, and I'm joined tonight by one of my colleagues, Kara Woodshank, who's behind the scenes helping with the technical stuff tonight. Just a couple comments. After our speaker presents, there will be some time for Q&A, and if you have questions, you can enter those in the Q&A box at any point during the webinar, or you can wait until we get to the Q&A. Dr. Markowski will get to as many questions as he can tonight. You can enable closed captions on your screen if you want to see what's being said printed out on your screen. So there's a box, should be at the bottom of your screen. It's a rectangle with the letter CC, and you just click on that and that'll start closed captions for you. A recording of tonight's webinar will be sent out in the next couple of days, as well as some additional resources. So with that, I will introduce our speaker tonight. Dr. Mark Markowski is a medical oncologist at the Kimmel Cancer Center at Sibley Memorial Hospital, as well as an instructor in the Department of Oncology at Johns Hopkins University School of Medicine. Dr. Markowski participates in multidisciplinary clinics at Sibley and at the Johns Hopkins Hospital and sees patients in the genitourinary clinics of both hospitals. Dr. Markowski earned his medical degree and PhD in tumor biology at Georgetown University School of Medicine. He completed a residency in internal medicine at Columbia University, followed by a medical oncology fellowship at Johns Hopkins Hospital. Dr. Markowski's research interests focus on early phase drug development for prostate cancer and anti-inflammatory agents and cancer incidence. He is currently conducting research with funding from a postdoctoral training award from the Department of Defense's Prostate Cancer Research Program and a Young Investigator Award from the Prostate Cancer Foundation. So with that, I want to welcome Dr. Markowski. Thank you for joining us tonight. We're all looking forward to your presentation, and I'll turn things over to you.
Well, thank you, Pam and Kara, for putting this together. It's a pleasure to be here. So this talk is basically a prostate cancer 101 talk, right? We're going to talk about what the prostate is, how prostate cancer develops, what are some of the treatment options for local prostate cancer, metastatic prostate cancer, and we'll end by talking about a novel way to treat some metastatic prostate cancer patients actually using testosterone-based therapies. So kind of to get things started, we're going to go over a little bit of geography. So the prostate sits between the bladder and the base of the penis, and the urethra that runs from the bladder out of the penis goes right through the prostate. And so as the prostate gets larger, either from benign enlargement or from prostate cancer, typically the first sign and symptom we have is issues with urination. Weak flow, trouble starting, trouble stopping, urgency, and that clues us into something is going on in the prostate gland. So some interesting factoids about the prostate that I discovered putting this talk together, that the first kind of mention of the word prostate came from, it's a Greek word that came from prostatis. I don't think I'm pronouncing that correctly, but it roughly translates into one that stands before. And that was attributed to Herophilus of Alexandria in 355 BC. So again, we're going to go into some history here. But it was used to describe that small walnut-sized gland that was located in front of the bladder. And when they started doing some studies on some of the Egyptian mummies, they put them through CAT scanners, and they actually found a mummy from 240 BC, roughly, that actually had metastatic prostate cancer that you can see in the skeleton. So, you know, as far as we know, as long as man has been around, men have had issues with prostates and prostate cancers. But it really wasn't until the 1850s when Dr. Adams first described a case of prostate cancer by looking at actual tissue. And he described it as a very rare disease. So unfortunately, that probably turned out not to be the case. And, you know, as we learn more about prostate cancer, particularly with life insurance policies. So in 1934, there was a report by the Metropolitan Life Company looking at some of the insurance records, and they found that prostate cancer, you know, as a cause of death was 0.8 per 100,000 deaths in 1917. It increased to 3.7 out of 100,000 in 1928. And for reference, it's 19 deaths per 100,000 in 2020. So as a country, we become more developed over the last 100 years or so, so has the incidence of prostate cancer in men, particularly in the United States. So kind of some food for thought there. Some interesting factoids about the prostate. So 80% of men will develop some benign enlargement of their prostate by the age of 80. So as we get older, the prostate kind of somewhat naturally gets larger, pushes on the bladder, gives us urinary symptoms as we get older. Interestingly, when you look at autopsy studies, so patients that may have died in car accidents or other causes, they found up to 40% of patients that are 40 years old actually had very small incidences of prostate cancer. Not clinically significant, but they were able to see it. So it's not just necessarily disease of old men. Certainly younger men have it, but it's just not clinically significant. We don't need to find it. We don't need to treat it. On average, there's about 200 new cases of prostate cancer each year in the United States, and about 30,000 deaths from prostate cancer annually. So there's still a lot of work to do in terms of the treatment and diagnosis of prostate cancer. And this is kind of a fun slide here. When you look at, the genital urinary organs of men, and I'm just highlighting a few here, the prostate, seminal vesicles, bulbourethral glands, they kind of all live in the same area, right? The prostate surrounds the urethra, the seminal vesicles and bulbourethral gland bud off of the urethra. All three are regulated by testosterone. So if you have testosterone, it kind of supports the development of these organs. But when you look at cancer incidence, the incidence of prostate cancer, 1 in 8 men will get prostate cancer, whereas cancer of the seminal vesicles, 1 out of 100 million. And then cancer of the bulbourethral gland has never been reported, right? And there was a great researcher at Hopkins named Don Coffey who died a few years ago and really dedicated decades of his life to understanding prostate cancer. And he always had these great kind of quotes, and this is one of them there. When you think about these three organs, they smoked the same cigarettes, ate the same hot dogs, had the same parents. One gets cancer and the other two really don't. Why is that, right? We don't really understand why do adjacent organs not get cancer, whereas prostate, it's quite common. One of the things that we found is there's actually a lot of inflammation in the prostate, right? So is it inflammation that is driving these changes, whereas we don't really see inflammation in other organs? Possibly, but more work needs to be done to understand it. It's just kind of an interesting factoid to think about. So what does the prostate do? Well, we think it secretes seminal fluid, during the ejaculation process, but it also may function as a barrier, protecting the reproductive tract from infection. And it really is a battleground site for either infection or actually inflammation, particularly in older men, right? So when you look at a biopsy report, they'll comment about cancer and normal, but we tend to see a lot of chronic inflammation. In the slide on the left side of the screen, it's very colorful, and you can see kind of what looks like almost a figure 8. That's the normal prostate gland tissue. But surrounding it, you see a lot of yellows and pinks and blues. That's the immune cells kind of living adjacent to the prostate gland. And we think that may serve as a precursor for the development of prostate cancer down the road. But what's interesting is that if you have a prostate cancer that metastasizes to the lymph node, right? And the lymph node's where the immune system lives, and that's the slide on the right. We're not seeing those yellows and pinks and immune cells kind of attacking that prostate cancer. So before you get prostate cancer, there's a lot of inflammation in the region. But once you get prostate cancer and the prostate spreads, it's more of an immune desert. The immune system's just not really interacting with that prostate cancer. We don't understand it, but it's interesting to think about that inflammation may drive it, but also inflammation is not going to cure it, if you think of it that way. And then lastly, one last factoid here, prostate cancer is a multifocal disease. Normally you think of organs that have cancer in it, it's kind of a focal lesion of cancer that grows and eventually spreads. But when we look at the prostate, there's actually different areas of cancer within one gland. So it's rare that you only have one spot of prostate cancer. And the top slide is a picture of a prostate that was removed. And it's a bit hard to see, but if you look on the lower right part, there's several focal areas of prostate cancer. It's not one contiguous ball or tumor. It's in different areas. And when you cut that prostate in half and look at it under the microscope, that's the lower slide, the areas that are circled in red is the actual cancer. And you can see that is very peppered. Whereas the yellow or orange areas, that inflammatory atrophy, so that the glands are changing, but it's not quite cancer. And then there's a blue area, there's a couple circles of blue, that's intraepithelial neoplasia or a prostate cancer precursor lesion. So it's not one area, it's multiple areas within the gland. Why does that happen? We don't know. All right, some more statistics. And so prostate cancer is not just a US problem, it's a worldwide problem. There's 1.3 million new cases of prostate cancer diagnosed each year, and it represents 15% of all cancer in men. It's the most common cancer in men besides the superficial skin cancers like basal cell cancers. And there's at least 360,000 deaths from prostate cancer each year. Okay, so lots of people diagnosed, lots of people dying from prostate cancer. Again, we need more, we need more research, we need better treatments to lower that number. And I think one other, fact that we'll look at a little bit is that there is a variation between countries, underdeveloped, industrialized countries. And so when you look at the slide, I guess it's technically in the middle, but the graph on the left side, these are European countries with a very high incidence of prostate cancer. And you can see from 1975, and this graph goes up until 2010, there's generally an increase in prostate cancer diagnosis. But again, you don't need to be a statistician to see those countries on the right side, a much lower incidence of prostate cancer. And they happen to be Asian countries, China, Japan. Why is that? Right? In the United States, higher incidence of prostate cancer compared to Asian countries. So maybe it's a lifestyle, a diet thing that predisposes, certain populations to develop prostate cancer, whereas others, it's just not. How about some risk factors? Age, obviously, right? The older we get, prostate cancer is a disease of the older men, typically 65, 75, around there. Race, African-American men have a higher incidence of prostate cancer compared to Caucasians or Europeans, with Asians having the lowest incidence of prostate cancer. Family history, so if your father or your grandparent had prostate cancer, you are more likely to have prostate cancer. And we think there are genetic susceptibility genes that may predispose you to get prostate cancer. Obesity, so if you're heavier, we think you have a higher chance of getting prostate cancer. That may have to do with circulating hormone levels, maybe higher in the peripheral fat. The data with diet and alcohol and smoking, it's a bit mixed, right? If you have a glass of wine a day, is that protective, where smoking is more harmful? The data is a little bit difficult to tease out. Same thing with active lifestyle versus a sedentary lifestyle, but we do think the more active you are, if you have prostate cancer, the better you're going to do in the long term. And then testosterone levels. There's been recent data showing that testosterone replacement therapy was not associated with an increased risk of prostate cancer. But, it certainly worries us when we think about testosterone driving prostate cancer. Does higher levels of testosterone or lower level of testosterone protect you or put you at risk for prostate cancer? Generally, the answer is no. All right, so again, prostate cancer in African-American men, they have the highest rates of prostate cancer in the world. They get diagnosed at an earlier age with a more advanced stage, and they're twice as likely to die from prostate cancer than those patients that are Caucasian or European. Why is that? Could be socioeconomic factors, access to care, early diagnosis, access to treatments. There could be genetic factors that are passed down in that populations that may predispose to the development of prostate cancer. And then also, we've alluded to this, diet, what you eat, what you put in your body. Are certain types of food associated with prostate cancer? The short answer is yes. Polycyclic amines from charred meats, grilled meats, tend to predispose patients to have prostate cancer. That doesn't mean if you ate barbecue every day of your life, you're going to get prostate cancer. No, but there is an association with certain types of food and the development of cancer. Just more statistics for you. In 2017, so a couple of years ago, there was an estimated 3.1 million men living with prostate cancer in the United States. right? So that's all comers, local disease, advanced disease, patients on treatment, patients are not. So 3 million men have prostate cancer, a lot. New cases in 2020, about 200,000 we talked about, and 30,000 deaths. Now, if you break it down by ethnicity, we talked about it. Black patients, higher incidence of prostate cancer and more likely to die from prostate cancer, whereas Caucasians are somewhere in the middle. And then Asians or Pacific Islanders have the least amount of prostate cancer and are least likely to die from prostate cancer. The median age of diagnosis, it's in the mid 60s, so 65, 66 years old. And the median age of death is 80 years old, right? So, that really does suggest that those patients diagnosed with prostate cancer do live a very long time with the disease. All right, finally, some good news, right? Over the last couple of decades, the death rate from prostate cancer has declined. And the reason for that has been the development of PSA testing, better treatment options, and death from other causes. And there was a movement, I think it was in the early 2000s, where we really started to move away from PSA testing. And there was a thought that we were diagnosing men with prostate cancer that never needed to be diagnosed. And so we'll talk about some of the guidelines in a second, but we really got away from screening more regularly for prostate cancer. Not everybody, but that was the general recommendation. And what you're seeing now, if you look at that 5-year survival curve, through the 70s, 80s, 90s to 2000, the 5-year survival rate was approaching about 100%. But you're seeing us come off that a little bit, and it's declining, right? Between 2010 and 2022, survival rates, the 5-year survival rates, going down a little bit. And we think we're starting to see the impact of the getting away from PSA testing now reflected decades later when patients may be dying from prostate cancer. And the guidelines have since changed, right? So in 2015, 2017, we started to move back into PSA screening. So the expectation is that curve may still go down for a few more years, but we're hopeful to bend that curve back up and get near 100% where we once were. Some unique features of prostate cancer, and if you're a person who has prostate cancer, you realize this, it is a very slow growing disease, right? That even if you have metastatic disease, the median survival, how long you live for, 13, 15 years from the diagnosis. So many men are living a very long time. And if it is localized, it's highly curable, right? So if we're screening you, detecting it early, there's a very good chance you're going to be cured of prostate cancer. What helps us as clinicians is that there are a series of unique proteins and biomarkers that we can use for diagnosis and treatment, right? So PSA testing, right? We're able to detect very low levels of cancer in the blood with a PSA test. We now have PSMA-based imaging, right? We can detect very small amounts of cancer and see it on a scan with PSMA testing. That not only is an imaging target, but it's also a therapeutic target with the use of lutetium PSMA and Pluvicto. It's also very responsive to hormone therapy. Almost everybody has a response to hormone therapy, and on average, the initial hormone therapy treatment is effective for about 2 years. But there's a range. Some men become resistant early, 6 months, and some patients go decades on just very basic hormonal therapy, that their cancer is exquisitely sensitive, and they have very long-term durable remissions from hormone therapy alone. Generally, hormone therapy is not considered curable on its own. So if you have localized prostate cancer, we're generally not going to treat you with hormone therapy alone. You're either going to get hormone therapy with radiation, or you're going to get surgery and we're going to remove it. So hormone therapy by itself is not curative, even though it will or remove the bulk of the cancer that's out there. And then if patients who have relapsed disease or metastatic disease, kind of without treatment or after several lines of treatment, what we tend to see is most patients develop bone metastatic disease, in addition to soft tissue metastases. So some signs and symptoms of prostate cancer, many of these we know, having urgency, having to run to the bathroom, difficulty with flow, weak stream, hard to start, hard to stop, blood in the urine, blood in the seminal fluid, having issues with erectile function. these are symptoms that, I think it's time to talk to your urologist and get examined. All right, so briefly about PSA screening. It is somewhat controversial because we're trying to understand the guidelines and not find cancers that don't need to be found, but we also don't want to miss those that need to be found and treated, right? And so using PSA is an effective tool. And if you look at the screening recommendations, you can see these are different organizations. United States Preventative Task Force, changed its recommendation from a grade D, which is essentially don't do it, to a grade C in 2017, which means you could do it, but you need kind of informed consent and shared decision making. So they kind of loosened up their stance a bit. The American Urologic Association may have the strongest recommendation. So they recommend against routine screening from 40 to 55 years old and shared decision from 55 to 69. The family physicians recommend against screening. And then American Cancer Society suggests that it's a shared decision. So essentially, there's not a perfect way to screen for prostate cancer. It's important to have the dialogue between yourself, your primary care doctor, your urologist about the risks and benefits of screening. So what is PSA? Prostate-specific antigen. It is a protein that is made in high levels by both normal and cancerous prostate, and it's only made in the prostate gland, right? So if you have your prostate removed, it's easy. Your PSA should be 0. We think it may have a role in fertility, although we don't really know the true function, particularly its function in prostate cancer. But it can leak out into the blood when the prostate gets enlarged, it gets inflamed or infected, and even cancer. So it's not a perfect screening test. There are other reasons to have an elevated PSA test. And it's typically made at high levels throughout the treatment course for metastatic prostate cancer as well. So we talked about this prostate cancer, shared decision makings. It's just important to make sure we're understanding the risks and benefits of screening, right? So if you have an elevated PSA, you're going to get a biopsy, which may carry risk of infection or bleeding or other issues. So it's important to know what you're getting into. And we may find that you have a very low-grade prostate cancer that we may not need to treat, and we may just need to watch. But if the patient decides to be screened, I think it's routine to offer a PSA and a digital rectal exam for men between the ages of 50 to 69, doing it every 2 years or so. No routine screening for men 40 to 50 years old. And then if you're older, if you're 75 or older, again, when we look at the median life expectancy, if you get diagnosed with prostate cancer, it's 13 to 16 years. That would put that patient near 90 before they really had any issues with their prostate cancer. So we generally recommend against screening for older men. And then if your life expectancy is less than 10 years, we think you're going to die with prostate cancer, not from it. Therefore, we're not recommending screening. All right, and then men who are at increased risk, you might want to start early. We talked about it, family history, African-American men, known genetic factors, BRCA1, BRCA2 mutations that may lead you to get screened a little bit early. If you do have an elevated PSA, I'm sure several people on this call probably have, you get a prostate biopsy that looks something like this. They use an ultrasound probe that sits in the rectum and allows that urologist to identify the prostate gland. And with a needle, we are able to sample different areas of the prostate. If you do have prostate cancer, you tend to get a Gleason score. So what's a Gleason score? So Dr. Gleason was a pathologist who looked under the microscope and gave a score 1 through 5, depending on how aggressive the prostate cancer looked. And he literally drew it out on paper, and you can see it here on the left. The higher the number, the more aggressive appearing the prostate cancer is. Right now, we don't go any lower than Gleason 6, and we go up to Gleason 10. So the most common pattern we see, plus the second most common pattern we see, gives us the full score. So you may see 5 plus 4 or 4 plus 5 equals 9. That tends to be our higher grade of prostate cancer, whereas Gleason 6 is a very low grade prostate cancer. If you want to know more about your risk of the cancer spreading to the lymph nodes or seminal vesicles, there's something called the Parton tables. Dr. Parton recently passed away, was a urologist at Johns Hopkins who came up with this scoring system where you could plug in your PSA, your Gleason score, your staging, and get an estimate of your risk of having cancer outside of the prostate. Gleason 6, I'm just going to throw this out there. I'm not going to spend too much time on it. But if you have a pure Gleason 6 prostate cancer, we do believe that it is really incapable of spreading from the prostate. The problem is not with Gleason 6 not spreading. The problem is, are you missing other areas of Gleason 7 or 8 on a biopsy? So it's very hard to determine whether or not that's true Gleason 6 because it's a sampling error, or, is there cancer that's hiding out there? So if you do have a Gleason 6, it's very, very, very unlikely that you would have issues with prostate cancer moving forward. Is it a cancer? Yes, we still technically call it a cancer, but most patients do very well. We tend to put those patients on active surveillance to see if there's other higher grade disease that comes down the line. That's a little bit difficult. You need to have serial biopsies, and there's really no treatment for those patients unless we see, that Gleason score worsen. And a lot of men drop out. They just get tired of doing it, or they get lost to follow up. So, it is difficult sometimes to follow these patients for a long time. There is a significant dropout rate. But if you do have localized prostate cancer, one of the treatment options is a prostatectomy, where they remove the prostate gland. The first description of a prostatectomy happened over 100 years ago in 1904, and clearly we've gotten better over the years. I think the big development was in 1983 by Pat Walsh, who was a urologist at Johns Hopkins, developed a nerve-sparing approach, right? So the goal would be to remove the prostate, but preserve erectile function, obviously urinary continence as well. So better long-term outcomes from a quality of life for patient doing it by the Walsh method. Some patients with localized prostate cancer can get radiation, right? So there's something called external beam radiation, and this is one of those heat maps that the radiation oncologists do to really get that radiation honed in on the prostate. In general, patients come Monday through Friday, and it goes 6 to 7 weeks. So it's a lot of, low dose of radiation over a long period of time. And then there's also something called brachytherapy, where they put radioactive seeds in that are about the size of rice pellets into the prostate gland that delivers radiation to the gland itself. So, same idea. We're giving radiation to the gland. We're just doing it through different means. And the good news is 60 to 80% of men with prostate cancer are going to be cured. So if you have local prostate cancer, the outcomes are quite good. Right. And Don Coffey said, after infectious disease, cancer is the second most curable disease in humans. And that is particularly true with prostate cancer patients. When we think about staging of prostate cancer, we're very good at putting patients in different boxes, right? Clinically localized disease, and those patients tend to see urology or radiation oncology, and then we're trying to cure them. Some patients will relapse in the form of a PSA-only relapse. So we don't see any cancer in the scans, but we know you have a prostate cancer because that PSA is detectable after prostatectomy. And that's when medical oncology, like myself, come into play here. And then patients will go on to develop metastatic disease. And then we can put them in different boxes of hormone sensitive, castration resistant, depending on the lines of treatment. So in 2004, this was kind of the treatment paradigm if you had prostate cancer. Okay, everybody got something called an LHRH agonist, which lowers testosterone levels down. That's the injection of Eligard or Lupron that you would get. And when that became resistant, we would add some older medicines like Casodex, which blocks testosterone from binding the cancer, nalutamide, flutamide, similar medicines, very old, crude AR or hormone blocking pills. Ketoconazole was an antifungal drug that helped suppress production of extra testosterone. So these were the treatments that we were looking at until 2004, when chemotherapy was FDA approved, showing a life-prolonging benefit in patients that had castration-resistant prostate cancer. So leading up to that, for decades, limited treatment options. In 2004, we got chemotherapy. And this is kind of what it looks like today, right? So we have a lot more treatments for those patients that have metastatic prostate cancer. And if you show up with metastatic prostate cancer, you're not just getting your Lupron shot. You may get it with chemotherapy. You may get it with more hormone therapy. You may get triplet therapy with chemotherapy, hormone therapy, Lupron, right? So we're really learning how we should be treating prostate cancer. We have more effective second and third line drugs, abiraterone, enzalutamide, apalutamide, all very good when you become resistant to Lupron in lowering that PSA. Chemotherapy is still an option. In addition, we have another chemotherapy, cabazitaxel, that we can use after docetaxel. We have a Provenge vaccine. We have radium-223 if you've got bone-only prostate cancer. And we've got lutetium PSA or Pluvicto after chemotherapy if your prostate cancer makes that PSMA targeted or PSMA protein. So we have a lot of options for you if you go on to develop metastatic disease. In addition, we have PARP inhibitors if you have the right genetic mutation. We're still working on clinical trials and novel hormone therapy. So this list is going to grow in the years to come. The bad news is that it's very common and our screening options aren't great. Okay, they're good, but they're not great. And treatment, as you know, if you've been on hormone therapy, has a lot of side effects. But the good news is that it's highly curable if we can detect it early. The death rate has been decreasing, although, recent changes are worrisome, but I'm hopeful with more PSA testing, we're going to fix that. And long-term survival similarly is improving. And there's new therapy. So, what we're doing in 2025 will not be the same as what we're doing in 2026, 2027, and beyond. So the treatments are always changing. And so I'm going to transition a little bit, and that's kind of our, prostate cancer overview, and we can go over questions. I'm going to kind of move into this novel way we're thinking about treating prostate cancer. And we'll start quickly with a history lesson. This is Charles Huggins. Charles Huggins was a urologist at the University of Chicago, who in 1941 discovered that testosterone was actually driving prostate cancer. And if you remove testosterone from the equation, patients were going to do better and live longer. And so for the last 80 years, we've been using hormone-based therapies, so castration or lowering of testosterone or blocking of testosterone to treat prostate cancer, but it comes at a price, right? Lack of energy, weight gain, no libido, right? Weakening of your bones, maybe some cloudiness of your thinking. There's a lot of potential side effects of hormone therapy that we don't like, but we use it because it really works. Right. So when you look at this, and if you look at the y-axis here, this is a patient whose PSA is rising. You can see the numbers going up. And then on day 0, that's the x-axis, we put you on Lupron, we lower that testosterone levels, and what happens? That PSA goes way down, right? That cancer starts dying off, pain gets better, tumors shrink down, right? It's this shock phase of prostate cancer treatment. And the hope is that that PSA stays down for a long time, decades, right? And you kind of go into this phase where that PSA is low. But inevitably, with time, the cancer figures out how to grow with this low level of testosterone, and the PSA starts to go up. And I don't want to get too into the weeds here in terms of the biology of it. But testosterone binds to something called the androgen receptor. We call it AR. And what happens is when you remove testosterone from the equation, from the body, AR levels, the androgen receptor levels within the tumor go up. So the cancer, says, look, you're taking away the testosterone. I'm going to make as much of that receptor. I want to hold on to whatever little testosterone you get until it gets to the right amount of signaling, right? A little bit of testosterone, a lot of receptor kind of drives its growth downstream. And that's what we think happens, that the level of the receptor kind of finds this sweet spot with the level of testosterone the cancer likes to grow. Okay, and this is a silly graph, but it kind of explains the point, right? So the cancer finds this sweet spot of the androgen receptor activity that maximizes the growth, right? And when we put somebody on Lupron, we remove testosterone, right? The signaling through the androgen receptor goes down very quickly, right? So the growth goes down very quickly. But what if we kind of really overstimulated the receptor and got it out of this sweet spot? Can we drop the growth of cancer by kind of overstimulating with testosterone, right? And it sounds crazy. And we came up with this idea of bipolar androgen therapy, right? Because if you have a neat idea, you got to give it a cool name. So we call it bipolar androgen therapy, where patients come every month, they get an injection in the muscle of testosterone. Now they stay on their Lupron, so they're not making their own testosterone. We give it to patients. And you can see by the graph, the testosterone levels go way up. All right, a normal testosterone level is say 400. Well, we're shooting it above 1500. And over the course of the month, that level will drift back down. And we do it again every month. We will go up and we go down. And what we find, and we're going to show some data, it's actually very hard on the cancer to adapt. So at high levels, it seems very toxic. And as it wants to adjust to the testosterone, it drifts down and we lower it. So the cancer has a very difficult time becoming resistant because the levels are changing. And so some of the keys, and we call it BAT for short, bipolar androgen therapy. And these are patients that have metastatic prostate cancer that have become resistant to the Luprons and the abiraterones of the world. And we keep patients on their Lupron, and we give them a dose of testosterone cypionate, which has been used to supplement testosterone, 400 milligrams in the muscle every month. And you really have to be asymptomatic from your prostate cancer, right? We don't want patients that are taking strong pain meds because they have back pain from prostate cancer. And we don't want worrisome lesions, right? If you have a tumor in the prostate that's squeezing down on the urethra, we don't want to make that process worse. So we worry if you have cancer in the wrong spot. But we were able to test this concept on patients. And this is a schematic of the very first patient. And so you can imagine going to the FDA telling them that we want to treat patients with metastatic prostate cancer with testosterone. You literally have to do it one patient at a time. And this was one of our trials, and we did testosterone with chemotherapy. And you can see this is the patient's PSA curve leading up to testosterone. PSA is creeping up. And with the first dose of testosterone, the PSA actually shoots up. And you can imagine looking at that going, oh boy, that's worrisome. But with time and more injections, the PSA starts to go down. And that patient started with a PSA of 22, and within a few months, it was down to 6. And we look at the tumors on the CAT scan. Pre-treatment, there's a couple of large lymph nodes that we can see that shrink down after 3 months of testosterone. And so this patient went on for about a year plus getting testosterone treatments with a pretty durable response. So by giving testosterone, we were able to control their cancer for a year. One of the other trials we did is something called the Restore trial. And this is a bit of a busy slide, okay? But we had patients who were on their Lupron and they were on enzalutamide. I'm just going to focus on the enzalutamide part of this. So enzalutamide's blocking medicine. So Lupron, enzalutamide, PSA is going up. So we take those patients off the enzalutamide and we put them on the testosterone treatments. And if they're responding to the testosterone, their PSA declines, we just keep them on the testosterone. But when their PSA starts to rise on the testosterone, we take them off of that and put them back on the enzalutamide, right? So every single person going into that trial had a resistance to the enzalutamide, treat them with testosterone, and then re-challenge them. And so now I know we're getting really in the woods here with some of the data. But now we're going to look at how patients did. So each one of these bars represents a patient, okay? And if the bars go up, that means their PSA was going up. And if the bars go down, that means their PSA was declining, right? So the blue here, we did 30 patients who were resistant to enzalutamide and treated them with the testosterone. And you can see more than half of them had their PSA go down, which is pretty good. And then there was a fair share that had a PSA go down more than 50%, someone down 95, 100%. Now, when those patients became resistant, we re-challenged them with enzalutamide. And this is the orange curve. And every single one of those patients, if you obviously, if you just put them on enzalutamide without the testosterone, the bars would be going up. But when you give them a whiff of testosterone, most of those patients had sensitivity again to the enzalutamide, right? So not only did some respond to the testosterone, but after testosterone, we kind of reverted that tumor back to some wimpier version where it became sensitive to that enzalutamide drug again. And it didn't matter if you responded to the testosterone or not. So this is where it gets really complicated, but we tried to pair the patients together, their curves. And you can see if you look at the bottom chart here, on the left side, the blue lines are going up. That means they didn't respond to the testosterone, but all of them responded to the re-challenge, right? And there's some patients that responded to the testosterone that didn't respond to the re-challenge, and some responded to both, right? So it doesn't matter if you were resistant to the testosterone, just by bathing that tumor in testosterone, we restored some sensitivity there. And, even if you're lukewarm on the benefit, like a clinical benefit, the shrinking of the PSA and the tumors, the quality of life benefits of being on testosterone were quite profound, right? We saw improvements in energy, fatigue, emotional changes, right? Patients' moods improved. They lost weight, put on muscle, right? And some of them were able to achieve and maintain erections while they're on treatment for metastatic prostate cancer. So they were able to we were able to see clinical responses in patients that had relatively asymptomatic disease. And we were able to restore some sensitivity to some prior hormonal-based therapies. And there is quality of life improvements using testosterone, including some restoration of sexual function. And I think that's about our 45 minutes, and I think that's all I have. So we kind of ran through that quick. I think I'm going to stop sharing, and we're going to work on some Q&A now. Let's see.
Dr. Markowski, it doesn't look like there are any questions in the Q&A quite yet, so we'll give people a minute to, put their questions in. But while we're waiting, I'm wondering if you could answer this question about BAD. Is that a standard of care treatment, or is that something a patient would receive only on a clinical trial at this point?
It's generally considered experimental. So most patients that we treat, we are treating on a clinical trial. But it's certainly something that we can discuss. I mean, we have had patients, do testosterone therapies at other sites with their local oncologists, and we try to advise them. But in general, we would consider that experimental therapy.
Thank you. And I do have another question since we're waiting here. It's really about the screening and shared decision making and conversations with providers. And when I hear someone, people like, physicians like you asking, talking about that, I want to ask the follow-up question, which is how, can you talk a little bit about that, and maybe, how do patients approach their doctors and get engaged in that treatment decision making? Do you have any other additional thoughts about that?
Yeah, I mean, I think that's such a good question, right? And somewhat it's a cop-out to say, look, you got to have shared decision making, right? Well, what does that even mean, right? Like, you're the doctor, what does that mean? Do I need to get screened or not, right? Like, it's always like the concept of it is somewhat foreign, right? But I think PSA screening is not perfect, right? No matter what cut point you use, if you want to set a PSA anything above 2, you're going to get a biopsy, right? You're going to find, obviously you're going to get biopsies that are negative. You're not going to find prostate cancer, right? So in that case, like, if you set the bar too low, you're not going to, you're going to find most of the prostate cancers, but a lot of your biopsies are going to be negative, right? And so you're putting patients through a procedure, they don't have cancer. If I set the bar too high, if I say don't come until you have a PSA of 10, well, most of those patients will probably have cancer in their biopsy, but you're going to miss a whole lot too, right? So we don't really know the ideal cutoff, right? We usually set around 4 as kind of, once you hit above 4, you should really talk to your urologist about it. But what we're trying to do, and we don't know the answer, is how do we find clinically meaningful prostate cancer? Meaning, how do I find prostate cancer that will inevitably kill you before it spreads? We don't have a good answer. So we screen and we find, Gleason 6 disease in somebody who's 90 years old. And you say, well, I didn't need to find that. That guy is not going to die from prostate cancer, right? So it's important, and I'm not giving a clear answer because I don't think there is a clear answer, right? But when you talk to your doctor, it's like, well, what are the harms that can come from me? Because it sounds like screening is a good idea. It's just a blood test. But maybe you have an elevated PSA because, you have chronic inflammation in your prostate or chronic prostatitis. You don't have prostate cancer. Well, now you're going to get a biopsy. And then you get an infection because they do it through a rectal probe, and you get an infection, you end up in the hospital with sepsis. You say, what do we do? And we got, you need to understand the risks that are involved with PSA testing, and it's not perfect. So I'm rambling here because I don't have a good answer for you besides, I think you just got to have a very frank discussion of like, why do I need this? right? Like, what's going to happen to me if my PSA is elevated? What's going to happen? What does it mean if my PSA is low, right? And I think, I just think you have to have an open dialogue with your providers and just be honest with it, and say, look, I don't understand. Please tell me, what do I need this? Do I not need it? And try to get the best answers you can.
Great. Well, thank you. That was a great answer, actually. I think, just saying that it is a little bit, there's gray area, and it really, hopefully the audience is, gathers that they need to approach their own provider and know that it's not black and white. There are a number of questions in the Q&A. I'll let you take a peek at those and see.
Okay, I'm going to start. I don't know which one's okay, I'm going to start at the top. For testosterone treatment, are you talking about treating men whose prostates have been removed? We're talking about men who have metastatic prostate cancer, right? So you can have had a prostatectomy, gone on to relapse and have metastatic disease, get hormone therapy. You can also have had treatment with radiation, right? And you may have relapsed later with metastatic disease. So the primary mode of treatment for your prostate cancer does not necessarily matter. We're talking about patients that have metastatic disease, that have been on hormone therapy and become resistant to hormone therapy. So that one, all right, so we did that one. Hope that answers that. Has there been any effects as far as testosterone dependency undergoing hormone replacement therapy for BAT? So the short answer is no. So let me say it this way. If you are a patient who has low T, okay, right? Like you're fatigued, there's commercials on TV, you got low T, and you get testosterone replacement therapy, then yes, you generally are dependent on testosterone replacement to maintain that level. Because when your body senses a normal level of testosterone, it kind of shuts down the testosterone making process, right? So, in that circumstance, you are. In our patients, they don't make any testosterone, right? We're lowering that with Lupron. They have very low levels. So when we treat you, we are controlling the levels. Sure, when you're on testosterone treatment, you feel good. Your energy level's good. You get the benefits of hormone therapy, or I'm sorry, hormone replacement. But if you become resistant to the testosterone, we move you on to enzalutamide or chemotherapy. You're coming off the testosterone. You're not necessarily dependent on it because we want to get your testosterone back low again and get you on conventional treatments. I hope that makes sense. Can you touch on low PSA producers, high glycin? Had a PSA 4.6, glycin 9. Does low PSA indicate that PSMA treatments might not be as effective? This is a great question. Okay, so testosterone will cause prostate cells to make the PSA protein. Okay, if you are a high secretor of PSA, then that testosterone signaling pathway within the tumor may be more active, and you may respond better to treatments where I remove that testosterone, right? Because that pathway is rip-roaring and active, okay? Now, the opposite of that, there are some patients that have low PSAs, right? That, PSA 4.6 probably gets you to the urologist, but let's say that you have metastatic prostate cancer, right? If I put you through a CAT scan, your PSA is 4.6, and I see a fair amount of cancer there, that PSA is low with respect to the amount of disease, right? So the amount of PSA being produced per cancer cell is low, and that hormone signaling pathway may not be as active, or which means you may become resistant to some of those hormone therapies that we'll use, like enzalutamide or abiraterone or Lupron. Like you may not, respond as deeply or as long because that cancer may not be dependent as much on that pathway as it is in somebody who is a higher kind of secretor. Now, PSMA is kind of in that same, genre, I'd say, right? PSA and PSMA, they're hormone influenced. But with PSMA treatments, right, you're getting a PSMA PET scan, right? So we are going to measure the amount of PSA kind of in your body before you go on treatment, right? So if your PSA is low, but your PSMA PET scan is on fire, right? You have tons of PSMA, there's probably a good chance you'll respond to the Pluvicto, lutetium, right? So I would presume you would have less PSMA if your PSA is low, but you just got to focus on the amount of PSMA to determine if you're going to respond to the PSMA, because you're you're not disrupting any signaling pathway. You're literally just taking a molecule that binds to PSMA that has radiation on it, and it's going into the cell, right? You're not disrupting any kind of signaling. It's like glue. You're just sticking it there and letting the radiation do its work. All right, are you trying this experiment in a situation where the patients experience slowly rising PSA 10 years post-surgery? So if you have a slowly rising PSA 10 years post-surgery, and you really don't have metastatic disease, you're not on hormone therapy, you don't need anything, right? You're going to live a long time. You're just going to watch that PSA. And the goal here is that you're going to, die many years from now with a PSA of 25, and you'll never know you have prostate cancer, right? So if you just have slowly rising PSA, presumably hormone sensitive, there really isn't a reason to do anything. If you go on to develop metastatic disease, then yeah, you'll go on hormone therapy. But I'm assuming that this is with normal testosterone levels in your body, a slow rising PSA post-surgery. All right, Jack, for patients that have chemically recurrent prostate cancer, do we think, where'd it go? Do we think that intermittent hormone versus still works the best option? So I am very much on board with the intermittent treatment, right? So when we look at, and you're going to get a lot of opinions on this, but when you look at the data, that continuous versus intermittent, okay? Some of the best data we have is a couple decades old, I would assume now, that the overall survival, right? If you took 1,000 patients in intermittent, 1,000 patients in continuous, those two groups are going to live the same amount of time. If you break it down, I think there's a slightly higher chance that you would die from prostate cancer with the intermittent approach. But there's also side effects to hormone therapy that may lead to, say, cardiovascular disease and shorten your survival. So at the end of the day, the overall survival is the same. Prostate cancer specific mortality is slightly better in the continuous, but I do a lot of intermittent. I think the quality of life benefits are great. You get, I just describe it as, hey, we're cutting the grass. We're going to get that level low, and then we're going to let it grow. Okay, and if that PSA is a slow, recover slowly, then you're going to be off treatment for a long time. And maybe we treat you 6 months at a time every couple of years, and you go on to have a great quality of life. That's the goal here. So that's what I do. These studies or treatments involve placebos. Generally not, right? When we look at cancer treatments, you are going to get the standard of care or better, right? You are not going to get some kind of inferior treatment. You may not get, you're going to get whatever we consider standard of care for that, stage of disease, whether it's enzalutamide or whatever. You're going to get that at bare minimum, and then you're going to get something in addition. Okay, so generally our trials do not involve, they have placebos, but you're going to get a standard of care plus something else, and that plus something else may be a placebo or or some experimental drug. We just don't know. It might be worth mentioning that no one should have a transrectal biopsy. Only transperineal makes sense. Don't think anybody is doing transrectal anymore, I hope. I agree with Dr. Lyons. I think that is moving towards a standard of care. Essentially, do you get a biopsy through the rectum versus kind of outside the rectum? I think the urologists are changing on that. I think they find it to be safer, just as effective, and they're doing more of that. So I think that is a very good point to make. I do see some biopsies that are transrectal. I'm not trying to trigger you. I'm just saying that there are reports that come through, not necessarily at Sibley, but at other sites that use transrectal. But it's a fair point. Transperineal is very commonplace. All right. Would bipolar androgen still be appropriate? The PSA was low, never higher than 3.4 prior to prostatectomy. Generally, can anything be said about the treatment responsiveness with low PSA? So, I don't think we've ever looked at this formally, so I can't say, well, if you have low PSA, the chances of you responding are lower than higher. I mean, we have seen PSAs respond to testosterone therapy with low PSA. Everybody is different. And it just depends on your kind of how you're feeling and what your treatment options are, whether or not you're eligible for a trial. But generally, our trial eligibility requires a PSA greater than 1. So when we do our bipolar androgen therapy, so if your PSA is above 1, you would be eligible. All right, I got one more here. PSMA PET in 2020 proved my biopsy in 2019 missed cancer. The tumor developed in the same location, sampled, but an error. PSMA screening now replacing biopsy, or is it deemed a better option is it deemed a better option now in clinical standards? So I mean, I think nothing replaces a biopsy to get a confirmed diagnosis. So PSMA PET scans certainly pick up other things besides prostate cancer. And I think it's not only the diagnosis, right? It's the Gleason score. It kind of informs how your cancer is behaving. And, there are, if you take tissue, you can send it for Decipher testing and get more info to help inform your treatment options, right? So, I mean, I think it's a nice tool to help us stage, but it's not, at least at this point, I don't foresee that changing in the near future. It's definitely not replacing biopsies. You should get a biopsy, and most patients get PET scans too. All right, did you get rid of, Pam, did we go through all of them or did we delete some of these?
You went through all of them. I just moved them to that they were already answered. There's one more in there in the Q&A right now.
Okay. Any risk from cancer being released from the prostate or spread from a transperineal biopsy? The short answer is no. I mean, I think, we always think about, whether you're going to seed the track. I think that's more theoretical. I'll say the answer to that is no. If there are urologists on the call who want to jump in, they can share that, but I've never encountered that. All right, what do we think?
I think I have one more quick question that, when you talk about metastatic prostate cancer in the bones, I think that people in rehab are extraordinarily helpful with patients and sort of recovering and coping with some of those kind of effects of cancer. I'm just wondering if I know this is sort of off the target of what you've been addressing, but is there anything you advise your patients who have mets to the bones in terms of protecting, obviously reducing risk of falls, but is there anything else people can do to protect their bones when they have mets?
That's a great question. And a lot of patients will take calcium and vitamin D supplements to kind of maintain good bone strength. Hormone therapy with time, not like months, but years of hormone therapy will make the bones a bit weaker. So some patients who have particularly high volumes of metastatic disease in the bones with a castration-resistant prostate cancer will go on something called Zometa or a bisphosphonate to kind of take that calcium, put it back in the bones, and really get it strengthened. But I think the short answer is, most patients, calcium and vitamin D makes a lot of sense. Some patients with higher volume in the bones will require bone strengthening agents, which are very good. And then, there are certain areas of the bone that are more worrisome than other, right? If you have a spot of cancer in the ribs, certainly is painful, and you can have a rib fracture, but I worry about cancer that's, say, in the hip area, where that's bearing a lot of weight, right? So if you have cancer in those real weight-bearing areas, we're going to have you see the orthopedic oncologist and make sure that bone integrity is good, and if you need surgery to stabilize that bone, we're going to do that. Right. So I think, there are supplements, there are treatments to strengthen your bone, and I think between your urologist and oncologist and even radiation docs, if there are worrisome lesions in the skeleton, we're going to bring in our, multidisciplinary colleagues here and make sure that we're maintaining good bone integrity.
Great. Thank you for that. Well, and thank you for the whole talk. It's nice, great to hear about new novel treatments that are in process, and you're working and using those with your patients when appropriate. And thank you for the basics too. I think it's always good to hear sort of the fundamentals of prostate cancer and sort of build on that as you did with your talk. So thank you for sharing your expertise and for being here tonight. Appreciate it. And I'll want to thank everybody for joining us tonight. When you close out from the webinar, an evaluation will pop up. We ask you to complete that. It gives us some feedback about how we're doing and how we can make improvements to future education that we offer. And again, we are recording this session and we'll be sending the recording out in the next couple days with a couple other resources. So thank you all again for attending. Thank you, Dr. Markowski, for presenting tonight.
You're welcome. Thanks for having me.
Bye-bye.